Wednesday, April 2nd. I'm Adam Walsh, and this is The Signal. Well, it's been more than 5 years since the start of the pandemic, a time that exposed the healthcare system on the brink. What did we learn from that time? What's the view from the front lines today? I've got the folks here to talk about that. So here's some extra show context for you. The idea for this show, like, 5th anniversary of the pandemic, right, last month, as it was approaching, myself, Arlette, Pike, we were talking about what do we do? What are some shows we should do? We're looking at ways to recognize it, but also look at what's happening now with a look forward. And then we started talking to some folks within the system. And I'm paraphrasing here, but here's what we heard. COVID didn't start the chaos in the healthcare system. It was brewing for many years. COVID just made the chaos not ignorable anymore. So with that, we have today's show. It's really not about COVID. That's just a point of the discussion in order to frame things up. Today's show is really about the healthcare system now and where we're going. If you have thoughts as you're listening to us, you want to send something in, the text line is open today for texting, 709-327-8206. Emails, thesignal@cbc.ca. All that being said, let's get down to talking the view from the front lines. A couple lines or a thought on the current state of the healthcare system from what you've been hearing from your members in recent weeks or days.
So recent weeks and days, all I'm hearing from our members is that they are absolutely in crisis out there. They're working short. They're working 24-hour shifts. And yesterday I became aware of 3 24-hour shifts here in St. John's this past week alone. One unit had 2 registered nurses working 24 hours on the one shift. Not sustainable, not safe for nursing staff, and certainly not safe for our patients.
All right, so that's one view. Margot.
From the nurse practitioner lens, we're really struggling with a lot of pay inequality, to be honest. We're tangled up right now in a job evaluation system process with government, with Treasury Board, to kind of help nurse practitioners get up to a little bit more comparable pay where they should be. And that's been a really difficult process for NPs. Clinically, NPs are really, really pushed workload-wise. We've seen NPs grow hugely in the province in the last 5 to 10 years. And the workload is just getting pretty intense for a lot of people right now, unfortunately.
All right, so nurse practitioners now for allied health professionals. Allison.
Yeah, so I guess first it's important for everybody on the line to know who allied health professionals are.
Yes, please.
So our union represents around 25 health professions, which includes physiotherapists, social workers, occupational therapists, respiratory therapists, psychologists, and the list goes on. So these are the members of your team that are there to support you in your health journey and work as part of your entire health team. So our members are certainly, we're hearing it every day that they're asked to do more and more and more on top of their regular workloads. And of course, that's putting a strain on our system, resulting, as Yvette said, in risk of the health of the workers and of the patients and clients that we service. And it's taking a huge toll on their own mental health.
Gord.
And Adam, just to add on to Allison's point, I mean, we represent a diverse group. They're quite a large group.
Quite the range.
We have 24 occupation classifications, and we hear different things from amongst the different groups. But one thing that we hear pretty much across the board is lack of communication and a crisis containment culture, and just feeling like every day you're just trying to keep ahead of things that probably could have been managed better or taken better control of at some point, but now it's become this thing that's gotten really overwhelming. And people do what they got to do when they need to, and our people are committed to that. All healthcare workers, I think, are. But it doesn't have to be that way, and it could run smoother and more efficiently.
Crisis containment culture. What does that mean?
I think so for me, I've had a 30-year career in healthcare.
Yeah.
It seems like it's just reacting and responding things. One classic example would be readmissions to hospital. So you're sending people home too early, and then they're back, and it's probably a bigger drain on the healthcare system. But even beyond that, there's a human being here that's, in upheaval and not getting the care that they need at the right times with the right people. So there's a lot of backtracking. There's a lot of trying to figure out, what do we do with this now? How do we make this better? How do we kind of pull this together? Doesn't have to work that way. Shouldn't work that way.
Anyone else in this crisis, does that ring true, or is there a feeling around crisis containment culture for your experiences with the system?
I would say that I 100% agree with what Gord is saying. It's not being proactive. We are being reactive. We did not get into the situation we are in today overnight. It wasn't COVID. COVID highlighted the issues and concerns when it comes to human resources. And the lack of a plan for health human resources is what has led us to the situation we are currently in. And we're coming with solutions. Some of them, they're listening to us and we're enacting them. Others, they're just, they're falling on deaf ears. And to hear, yesterday we met with a group of nurses. They've had several meetings with leadership, with management, with human resources, with our labour relations officers from the office. And then I had to go to the meeting, me and the executive director, and had to look at them and demand, if you do not have the skill mix, the proper staff in place, you have to close those beds that you opened. Because that's not safe for anybody. You're burning everybody out. And to Gord's point, at the end of every single decision and every single moment in healthcare is a patient, is a human being. That's our family members, our loved ones, as well as everybody in our communities throughout Newfoundland and Labrador. And the lack of a federal health human resource strategy is also there. We've done work here provincially. We do have Dr. Megan Hayes leading the Health Human Resource Department now with the Department of Health. However, we still have major concerns with the hiring practices of NLHS when it comes to new graduates because they're not hiring them permanent full-time. They're trying to force them all to go rural, remote, and underserviced areas. There's skill mix issues there. Brand new grad, and you're going to drop them in a rural community, and they're it. They're probably on call by themselves. So we're setting people up for failure. It is crisis containment. It is reactive, and we need to be proactive. And we need plans in place. If we don't have the staff, I'm really sorry. And I know I was part of the surgical backlog task force. And I know that we have major wait lists. But if we can't safely care for people, what are we doing here?
So when you bring that up, right, when you were brought into the meeting, like you just said, so the folks are having a meeting and then you get brought in. What's the response on when you're saying, wait a minute, skills mix not there, I have safety concerns, these beds should not be open, or this should not be happening the way it is? What gets told to you?
We'll take that back. That is the response in every single meeting that I attend with our members. And
take that back to who?
Higher leadership within NLHS.
Okay. Anyone want to expand on that or go? Yeah.
I'd love to expand on both what Gord and Yvette have said, because Gord was talking about the readmission rate. And of course, my background is primary health care, as well as long-term care, actually. And my nursing background is community health nursing. So I really only know that community end. But one thing about healthcare that's so interesting is that it's a very complex little ecosystem we have here, because every area impacts the other. Like what's going on in acute care impacts mental health and addictions, impacts community and public health, impacts primary health care, impacts, and that cycle continues, right? So when Gord is talking about readmission rates, we'll get a patient to be discharged from hospital. And first of all, it says follow up with your family doctor in 1 to 2 weeks. First of all, You don't necessarily need a family doctor. You can see a family doctor or a nurse practitioner. Both will give you high quality primary health care. So the language needs to change there. But we need to make sure that we actually have that capability to follow patients after a hospital discharge. Patients going into hospital now and patients living in the community are so much sicker than they were at one time. And when they go into hospital, there's major medication changes, there's major treatment changes, that if you don't have that ability to connect with them and kind of create that continuity and follow up, they're going to represent. That's what's going to happen. So we really need to focus on creating that environment where we can create continuity of care. It's one thing to say you have a primary care provider. If you can't see them for 6 or 8 or 10 weeks, do you really have a primary care provider?
Right.
You know,
what's the
the
difference
tree
between that and
falls
a
in the
walk-in
forest,
clinic? Yeah,
right?
of course.
So, you know, and the other piece to what Yvette was talking about in regards of safety and all these, you know, kind of conversations we have, the term I use, and I'm probably getting spicy early on, but the term I use is gaslighting in a lot of ways because, you know, we're hearing from members every day about they're working short staff, they're working 16, 18, 24-hour shifts. You know, I'm getting asked every day to do overtime, to do extra clinics, to do all this stuff. I'm feeling overwhelmed. I feel like I can't meet their needs, all this stuff. And we bring it back to leadership or management, whatever you want to call it. And it's very much like, oh, is that happening? I'll have to bring that back. I'm not sure. I'll have to look into it. And it's almost like a lack of acknowledgement of the reality, I guess. And that's what's frustrating as a frontline worker for me, not just me personally, but the members that I represent. It's really hard to hear that.
Yeah, I get their levels for decisions and stuff, but if you're only told, let me bring that back, right? We got to go, but without actually being like, hey, and seeing that there's an understanding of what folks are going through, I can see how that could be, you know, that happens once, it's frustrating. If it happens repeatedly.
And it's happening repeatedly. And, you know, the phrase I'll always use is, you know, people blame COVID for a lot of what we've struggled with. And I think COVID is maybe 25% responsible. You know, it was obviously an unprecedented event.
Yeah, pandemic, global pandemic. There's a lot of stuff.
For sure. We're fine with that. But it put pressure on a system that could not withstand any pressure. And it put an extreme amount of pressure, causing just a lot of crumbling to happen, which is, I think, where we're at right now.
I feel like it just exposed the wounds that were already embedded in the healthcare system. There was a lot of things there, and there were so many healthcare workers, health professionals, who were doing their absolute most and their hardest to keep it together, holding it together. And even on the front end of the pandemic, I just think about being on the front line myself. There were so many people who just grabbed and ran and did what they could do, wanted to be there, wanted to be part of the solution, wanted to keep people safe, people well. But it went on a really long period of time, and people just got exhausted. And we've never really had time to regroup from that.
Yeah, with that, a lot of during the pandemic and coming through, and I know that it's still, ongoing. A lot of folks took stock, and some retired, and then it's like, oh, this life balance thing, and there's all these different discussions. I've done shows on like, what's your work-life balance like now as we take stock on life? But then from what I get from the health crowd, it's like we were the dial went to 10. We were operating at 11 or 12 the whole time, and the only taking stock is the folks who quit because they were like, I'm done with this. How is that sitting now when you're still working at this level? You're throwing out words like gaslighting, folks not listening. How is that sitting with you all right now for where you are with your lives and what you're trying to do with your own lives and functioning?
I think a lot of people are struggling with that. And the thing that I've noticed of late is, and this goes back to Yvette's point around workforce recruitment and retention, and particularly retention, skill sets that are walking out the door, people opting to leave early, retire early, looking at options that they can do. Nobody wants to hang around longer, which is really sad. And when you have people leave and you know there goes 30 years of service, and maybe in another place and time they might have hung on another couple of years and shared that expertise and mentored a few people before they left. We're not seeing that now, and that is so sad. And so while we see a lot, and I look at Yvette and we've advocated for recruitment incentives and things of that nature, the retention is huge. We need to hang on to those skill sets as long as we can.
Absolutely, Gord. I mean, the retention piece, we've been recruiting, and, Minister Haggie said recently in the House they've recruited 900 nurses. Well, I'd like to see them all, because we still have over 500 registered nurse vacancies, 81 nurse practitioner vacancies. So then you add to that, you don't have a physiotherapist to help get patients up after surgery. You don't have a social worker there all the time. They're probably divided between 3 or 4 or 5 units, a social worker and a physiotherapist being shared amongst units. And guess who that work falls on when all of those other healthcare professionals are not there? The primary caregiver, which is your registered nurse. Or a licensed practical nurse, for that matter, right? So we're just spinning our wheels. That's how I feel, and that's how our members feel. Healthcare is a team. None of us can do it alone. None of us. And the lack of healthcare providers, and I mean everybody on that team, is taking a toll on everybody. But it's really taking a toll on the services we can provide in this province, and also on the care that we're giving to the people of Newfoundland and Labrador.
Then tell me about, so we're talking folks spinning the wheels, not being heard, this day-to-day, not enough staff, skilled mixes are not mixed properly, adequately, nurses 24-hour shifts. But then what else are folks facing on the day-to-day at work? Now, I'm thinking physical health, right? Because there's stuff in the news that you've talked about, Yvette. Mental health. Paint that picture for people listening.
I got to give you an example I heard yesterday.
Okay.
And that example was a unit that is so short-staffed, with 11 registered nurses leaving that unit with their skill and their expertise. The lack of a physiotherapist to help with the post-op patients. So you have your surgery and we want to get you ambulating, get you moving. So the lack of all those resources on that unit, but they went ahead and opened beds. And there was a couple of people on ease-back from workers' comp, from injuries sustained at work.
Loads of injuries in healthcare, right? From day-to-day work. Yeah.
And the healthcare provider sent a report to Workplace N.L. saying this person's ease-back is not going well because there's not enough staff there to support that person's ease-back. So even trying to get people back into the workplace is being impacted by the lack of resources, the lack of staff. But yet the pressure is on. And we understand that pressure. All of us here understand the pressure. Surgical wait times, procedures. And yes, we all want to get in and get our knees done and our hips done. But we have to do it in a safe manner.
That nurse, right? Because you started the show, we said, at the end of all this, it's a patient. The other thing I'm thinking of, how many of us have relatives working in the healthcare system? I think everyone listening now would be like, oh, me. I think those people too, right? That ease back person, and then, trying to get back to work. The stress of, okay, what am I going into? And then it's not going well. And then the family dynamic there. And in a time when we talk about the label of being a well-being province, the importance of social determinants of health, right? These are the things that are in my head around that. Anyone else want to jump in on that?
Well, Adam, that's part of what I was thinking too, because one thing that we're hearing consistently from right across our membership, whatever occupation group you want to talk to, is the complexity of the cases that they're seeing is much more challenging.
Yeah.
A lot of it has to do with determinants of health.
Yeah.
People who don't have financial resources. So it's great to say you need a raised toilet seat when you go home, but maybe they don't have the resource for that.
Can't afford it. And maybe these are folks that might be lucky to even get to an appointment on time if they had to take public transit or if they live in rural Newfoundland, the rural urban divide. All these things that can be stacked, sure.
Absolutely. And the housing crisis has impacted. So you might have someone who maybe during an admission lost their apartment. So now you're trying to find them a new place to live. And just feeling like at times there's just nowhere to go and nowhere to help these people. You know, in healthcare, we work with a lot of vulnerable populations. And my take on that is that anyone who's unwell is vulnerable. I don't care who you are, really, what socioeconomic status you come from. But we do work with a lot of vulnerable populations. And the complexity, the lack of resources, you know, even something as simple as the informal care network that was always so alive and so strong in rural Newfoundland. So you could send a lovely lady home to her home in Catalina, and she probably had her daughter next door, because the Newfoundland garden families, we all know that.
Oh, yeah.
But, you know, sometimes now you'll talk to someone, their closest relative is in Halifax. And where do we go with even looking at a sensible discharge plan if they don't have any supports around them?
Yeah, and we're certainly seeing that in the community, because that's where I work, is in community supports. We see that people are coming home without that discharge plan, and there is nobody to rely on. It is left to our program to try and do what we can to support our clients, and that just adds more and more to the work. They are sicker. They are coming home sicker. Mm-hmm. And we are doing what we can as a team to reach out to our partners and go back and forth with other teams. So we on Frontline are certainly trying our very best to create that sense of team. But when you don't have that full complement, it makes the work that much harder and that much more frustrating.
I will say, and just to plug for a second, tomorrow's show, right? Because we're talking here about health. Tomorrow, we're looking at the aging population of this province and the demographics of this province, and we're exploring what it means to stay longer in the workforce if folks want to. The cost of living, long-term care homes, which has been in the news this week with reports from the Auditor General, and anything impacting seniors today and folks who will be seniors of tomorrow. The phone lines will be open tomorrow for that show, but just when we talk about it all being connected, right? It doesn't take much to think, oh, wait a minute, rural-urban divide. Wait, you want to age, you want to perhaps stay at home, but all of a sudden you can't. Well, where's the nearest care home? Oh, it's 3 communities away, right? And then, or if you're within a brick-and-mortar hospital, and then we look at what you're saying, Yvette, about staffing and everything else, it doesn't take much to see the pressure points all over the place within the system. But there's a health accord. How is that moving along? Because there have been massive efforts, right, to look at this healthcare system, to either reinvent it or repurpose it for the healthcare that we need today and tomorrow and beyond, and to tear down silos and all of that stuff. So that's ongoing. I've heard a lot of it. We've talked about it a bunch on this show. What are your perspectives on the health accord and, how it's functioning?
Well, I participated in the health accord and the task force. Allied Health did as well. One of the things they talked about, and we have an aging population, and I keep hearing in the back of my head my mom saying, old and only in the way. It's a saying we used to hear in our community growing up.
What community was that, by the way?
Angels Cove on the Cape Shore.
Right.
And beautiful Cape Shore, I'll say. I think about that every time when I see the reports. You just referenced the AG report and the report from the Office of Seniors Advocate. Yep. And, Health Accord talked about aging in place and people be able to stay at home. So you have more supports in urban areas. We do not have the home care workers to be able to allow people to age at home. And it's not just aging at home, it's aging at home gracefully. As well, right? They got to have, quality life. So we're not there with that. I think it's a great recommendation because who wants, it's cost to the system, long-term care, personal care homes, and we've heard the issues there as well. But I think our biggest focus and our biggest issue is retention. And one of the things we've been talking about very loudly, and it's all of us as the healthcare unions, is about the violence that is being faced on a daily basis. I know you can't. You probably can't give a complete specific example of something depending on the details. But when I hear violence, there's many things that come into mind, right? When we say violence, what do we mean? We had one of our registered nurses have her nose broke by a patient, and the rest of her co-workers had to then care for that patient. So that's the difference. If you go into any grocery store here in St. John's metro area and somebody assaults you, because this is assaults, you're taken out in handcuffs. You do it in healthcare, yeah, we're still going to look after you. And the support, the culture has to change. People have to realize it is not okay. And it's the public. And I do have a message for the public. We know you're frustrated. We all are as well that work in healthcare or have dealings with the healthcare system. We know that, increased wait times. There's overcrowded emergency rooms. We have long-term care, and there's not enough staff there to be able to get your loved one up every single day in a chair, because we don't have the people there to do it. But that does not give you the right to verbally, emotionally, or physically assault and abuse healthcare workers. And I'm talking like the clerical people. They are at the front line that do your registration when you walk in, and they are abused on a daily basis. We have one every second day registered nurse filing a claim with Workplace N.L for injuries sustained at work.
One every second day.
One every second day.
Okay.
And that's not all violence, but it's because of short staffing. It's because of lack of equipment in some cases, lack of resources. And the retention piece is we need to be addressing that. We need to be addressing the violence. And I did speak with someone from Newfoundland and Labrador Health Services yesterday who is working on that. They did do a survey with all the employees of NLHS last year, a year ago now. The statistics that he read out to me yesterday, 75-80% of staff have experienced violence or abuse in the last year. If this was a construction site and that was going on, there would be a stop work order until things were sorted out. But because we are publicly funded and providing a public service, the show must go on. No matter if you have enough people there or the right people, we need to be looking at retention. People today, I'm a seasoned nurse, 35 years, and worked in the system for 31 of those. And what we put up with back in the 90s, people today are not putting up with it. And I applaud them for speaking up and saying, no, that's not acceptable. But we need employers to get behind this. We need the public to help us out here. We are doing the best we can, every single person that's working in healthcare today. But if we want to retain the young nurses coming out, the physiotherapists, the social workers, the licensed practical nurses, the nurse practitioners who are providing primary health care when we have 45,000 residents who do not have access to any kind of health care whatsoever except for emergency services. If we don't work to retain all of them, I don't know what's going to happen with our system and our aging population.
Before we put it back to the rest of the panel, with that level of violence, when you talk about it to the higher levels, the deciders in the system, whether it's with the health authority or the provincial government, what's the response there?
Well, in 2019, we brought everybody together, all stakeholders. We had the RNC, we had the RCMP, we had the employers. It was 4 regional health authorities at the time. We had healthcare workers, frontline, everybody. And there's a beautiful report that came from that, collecting dust up in the Confederation building. That's what's been done.
Okay. And as we said at the start of the show, pre-pandemic, these are through lines, right? Issues that were there before, perhaps compounded or at least paid more attention to for a bit. Now here we are, and it is, what year is it, 2025? Hard to keep track of time sometimes.
6 years.
6 years. So you're listening to Yvette Coffey, the president of the Registered Nurses Union. We've got Margot Antle here, a nurse practitioner, board member with the union, Allison Hussey, physiotherapist and incoming vice president for allied health professionals, and Gord Piercey, social worker, who is the president. Anyone want to either respond to what or add to what Yvette's saying, or thoughts on when we talk about that health accord and the push forward to try to get a system that is working for everyone?
Adam, I can, I guess, offer comments on both.
Sure.
From the nurse practitioner lens, for the most part, just because of the nature of our work, yes, there is physical violence for sure. But nurse practitioners will often get verbal abuse, right? And our staff, I mean, even in my role, I've actually had to say to my own patients, you cannot speak to my clerical that way because it's not appropriate. And they're not my clerical. I don't employ them, but I call them my clerical. But, you know, I think, as Yvette said, there needs to be accountability on both ends, right? Everybody is stressed. And I think in the last 5 years, we've seen just across the board, everyone is more reactive and activated, right, in society, and for probably pretty good reasons. But the physical violence is one thing and obviously has huge impacts. But, you know, that emotional toll that a lot of this takes, and it's not, yes, it's sometimes, you know, the things patients or other, sometimes unfortunately other staff members will say to you has an impact. And again, in that moment, you may be upset, but you have to carry on and do your work and carry on with your day. It's not just always that. It's these really difficult kind of ethical situations we run into when people don't have the resources, when they don't have housing. How do we get their medications covered? How do we meet their needs? That's a real emotional distress. And when whatever role you're working in healthcare, you don't clock out at whatever time you clock out and go, okay, I'm good, I'm gone home. Some people do, maybe. Good for them. I can't do it. But, you know, those things weigh on your mind. And when you think about what's contributing to burnout and what's contributing to, you know, retention issues, you can't continue to go to work every day and feel like you're not being successful and not getting something done. You can't every day feel that there's always a battle, that you're always arguing with somebody on an upper level to be heard or to get what you need or to get what your patient needs before that really starts to weigh on you and weigh on your mind. So that's, I mean, we've had many nurse practitioners leave the public system in the last number of years. You know, whether they're leaving the province, whether they're going to private opportunities. And that's what I hear often is that I'm saying all these things, I'm expressing these concerns, I have these worries, and nothing is getting done, and I can't deal with it anymore, and I don't have to deal with it anymore because there's another option. And that's my concern, is that as there's other options coming available, nursing and nurse practitioners, any healthcare provider is a finite resource. And unfortunately, our employer sometimes acts like it's not. Our employer acts like nursing. We don't have a nursing shortage. They treat people like there's no nursing shortage, that we're a dime a dozen. And I'm here to tell you right now, when you look at experience, we are not a dime a dozen. And that view needs to change. We need to be treated like the professional, experienced professionals that we are. And oftentimes that's not happening.
What about you folks?
Absolutely. I mean, the violence is absolutely unacceptable. I mean, and there's not only the instance of violence, but I'm also hearing from a lot of our members about just the worry, just knowing they're going into unpredictable situations. And even if nothing happens, that also takes a toll. So I've heard from people working in various areas just saying, you know, I know this is a stressful situation, or there's a lot of people really upset. You know, we know that people, one of the things I think is happening is people are waiting too long because they don't have access to primary care. So they're probably waiting too long. They probably got a health concern for a long period of time. But it just gets to a point where they finally surface and they emerge because that's the only place they've got. And they go, and they're probably really at the end of their rope at that point, not justifying a violent or an inappropriate action, but I think that's a piece of what's happening. And I think that speaks to the wraparound when something inside the healthcare system, you know, I worked with a manager one time. She always used to say, we're moving the logjam further down the river. And I use that analogy because if primary and community is broken, it's going to impact on acute care. When acute care struggles, then long-term care takes the brunt of that. You know, we know mental health and physical health are intertwined. When your mental health's not good, your physical health's not good, and vice versa. So we know, and people are much more in tune to that these days. So speaking to the health cord, you know, we talked about determinants of health. We know it's there, but I feel like it really needs to start, like we need to live the value of that. And I'm not sure we're there yet. So, you know, I need to get you out of acute care no matter what. that's not really dialing into the fact that there are people struggling. I have no one to look after me when I go home, and I can't walk. I don't know if that's the right home for my relative. I don't know, how long are we going to be waiting for this procedure? Like, you hear so many of those things. So the frustration is real, and we need to wrap that piece around better so that everything is kind of working. Too many silos in healthcare, and we've talked about that an awful lot, and talked about that. And I'm looking at Yvette. During the health accord, we talked about that a lot. About we got to get out of these silos, and we got to have that flow, that care flow that should meet people's needs wherever they're to and whatever they need.
Sorry, go ahead, Allison.
Yeah, no, I was just going to add that it really, just to elaborate on Gord's point, the employer really is focused on beds and processes rather than the people, that being the patients and the employees. Because at the end of the day, we are still people, and we have our own needs and mental health needs and struggles, and we can't just be expected to park that at the door and carry on.
No, we're not AI robots, right? We're members of the community everyone deserves the ability and the right to thrive in life.
Absolutely, and we all have our breaking point. Some of us who've been around a long time, I've been in this 20 years, and never thought that I'd reach a point where, I've had enough. Within my small team alone, we have all reached that point within the past week with various things, various stressors. Might have been an email from an angry family member who probably were also at that breaking point and their lowest point. But we still have to carry on.
I was about to use the word so we're at a crossroads, but I think I've probably said that on the air, in the last few, I could keep saying it. So we're at this point. There's a bunch of different ways we can describe it. I think anyone listening to the show up until now is getting a healthy perspective on what folks are facing. What now? What next? You have a health accord that's trying to kind of get through stuff. You have all this input here. We're talking silos. I'm also hearing about in my mind, I always thought silos were kind of up and down, right? Like over a department or building. But I'm also kind of imagining this horizontal silo of the different levels from there's the folks on the ground, and then there's this managerial silo. This is just from the pre-interview, talking to you folks beforehand and today. In my mind, that's how it works. Tell me if I'm right, wrong, other, and how do we move forward here in your opinions? Because it's retention, a few other things, but fill me in on what you think will fix or at least make things less bad, according to you.
I think we've all said, it sounds pretty negative and doom and gloom, but we are still health professionals, and at the heart of it, we do still want to care for our patients and clients and work together. So we are still optimistic. Yeah. We're absolutely ready to move forward and help at all levels to put these plans in place. And I think at the heart of it, it's that communication and talking to the right people who can help to move things forward. We see a lot of programs and pilots being introduced without talking to the front line and seeing, do you think this could work? Or what would we need in order for that to work? So that is a gap. But we are here. You have the right group and set of professionals available at your disposal. Use us. Talk to us.
But a pilot program will be brought in, and it's kind of did anyone talk to the staff about that? And then the answer seems to be no, which is...
And that has had implications, because you still need staff to staff these pilot programs. Where are they coming from? I always say you can't knit a physiotherapist. You have to plan and think about that before you implement this. Yes, chances are it's going to come from another area. You're going to steal from one to feed another, but that's where that creativity with the recruitment comes from. In our group of professionals, a lot of them are trained outside the province. We can't look within, right? Mm-hmm. So I myself was trained in Halifax. And a lot of our professionals are trained across the country. We need to get creative and go outside of what we know in our people and really look at recruiting people in.
So if a pilot project is brought in and no one's been consulted on the ground level for Newfoundland and Labrador, where does said pilot project come from? How does that get, who's coming up with this stuff?
The employer, and without consultation with even us as union leaders or the unions that represent. I heard tell of one that they took registered nurses from community health and put them into a pilot project in fee-for-service physician clinics. So who replaced them in community health? Like, community health is exploding with not only the number of patients and clients, but also the acuity of them, like the condition they're in when they're coming out to community. I'd like to talk about some solutions.
Yeah, please.
And we brought forward solutions, all of us, collectively. One thing the Health Accord did say, and we all agreed upon it, is everyone should be working to their full scope of practice. We have licensed practical nurses in this province who are not working to their full scope of practice, either in long-term care or in the acute care settings or community. We have nurse practitioners. 45,000 residents in this province still have no access to primary health care. We just did a survey with our nurse practitioners with Newfoundland and Labrador Health Services and the Department of Health and Community Services. Over 80% of them said they're willing to go to rural, remote communities, underserviced communities, to do what's called a locum. So they'll be working in St. John's and they'll say, okay, I can go to Bonavista for 2 weeks to give access to primary health care. No one's taken us up on that yet. Like, we talk and we talk and we talk, but nothing has come to fruition yet. And expanding the role of nurse practitioners so that they have the ability to be able to do that. Scheduling models so that if you got 4 nurse practitioners in a clinic, they can decide, okay, Margot, can you go to Bonavista next week? They're really short. They have no one to see the patients. And Margot says, yeah, and the other 3 will cover her patients. The other thing, too, is the core staffing review for nursing that we negotiated in 2019. Still hasn't happened. So we're operating all of our systems, community health, long-term care, and the acute care, like the big hospitals, on decades-old staffing models. And also basing it on numbers. I had a knee surgery back in 1992. I was in hospital for 2 weeks. That's an outpatient procedure right now. Many things have gone to outpatient procedures. So what we're looking after in the acute care settings is the sickest of the sickest. We have people who do not have access to primary health care, and by the time they show up in our emergency departments throughout this province, they are so sick. Some of them are actually diagnosed terminal upon being seen for the first time in years because they had neither a nurse practitioner or a family physician or any healthcare worker lay eyes on them. And that's the thing. Everything is about a team, but we need that team. And we are coming with solutions. We're having good discussions. We have been thinking outside the box. We've got a couple of things now, in the fryer, ready to sign with NLHS and with government. But the other thing is our new grads that are coming out, not even getting hired. And they're looking elsewhere. They're being offered float positions or they're being offered alternate scheduling for rural, remote, underserviced. Well, if you already have a house spot in St. John's or in Gander or in Corner Brook, you're not moving. You want to stay where you're to. We have travel agency nurses, which has cost us almost $750 million so far in this province, private agency nurses. And we're turning away new graduates for permanent full-time positions where they're living to.
So then what's the answer for the rural remote areas that folks don't want to move to?
Well,
you mentioned the locum part. Yep. Is that it, the floating locum parts
Yep.
for nurse practitioners? That's one way to kind of...
That is one. And we've already got one with the registered nurses with Labrador, right? And nurse practitioners. We have a travel locum, $25 extra an hour premium. And when we were having our early discussions about that, our vision was, this is not just about nursing. This is about occupational therapists, physiotherapists. We could all be doing that around this province. Right now we have traveling orthopedic surgery teams to go out and try to get at the backlog of orthopedic surgeries. We're going to St. Anthony. We're going to, I think, Stephenville we're going to do. But you need all the care providers, too, to be able to do that, to have that flexibility. At the end of the day, you are my dad used to say, you can't expect to have the health science centre at Placentia. So how do we get the care to these individuals who may not have transportation? Because we do have to look at all of that. Do they have supports at home? Do they have the finances? We all need to be working together, and we are coming with solutions. And government has enacted some of them, like childcare for healthcare workers. But we got a lot more work to do.
Yeah, so it's more listening, more pulling the trigger on these ideas that are out there, take the action, and hear what the ground, the bottom, the front line, the boots on the ground folks are saying, and taking that into account. I mean, there's a lot of what I'm getting from this conversation. What else for doables, achievables, movement forward?
Communication's imperative, absolutely, and you've heard that from all of us. But even just looking at some of the stuff around rural settings, one of the things we hear from our membership is, the reality is sometimes you get a new grad to go out to one of these communities. We're a lot of far-flung communities in Newfoundland and Labrador. It is what it is. We know that. But one thing we hear is that sometimes it's not even an unwillingness to go there, but if you're going out to a small rural community and you're going into a sole charge, which often happens in our membership, so you're a sole charge physiotherapist in a little hospital, wherever that might be, feeling supported. So I'm a new grad, and I want a link to a senior physiotherapist, someone who's seasoned, who knows what they're doing. And again, not that a new grad doesn't know what they're doing, but they do need that expertise and they need that available to them.
Experience matters, yeah.
So all that stuff is really important. But when you go out to those small communities and you feel like you're not getting that link, then maybe making a move to St. John's makes a whole lot of sense. Mm-hmm. And maybe you just feel like this isolation's not working for you and things of that nature. So there are so many things that can be done to get those skill sets in these communities. And, again, the retention of seasoned people, but also doing good recruitment. Like, there's a lot of good things there. The other thing, too, Adam, just to wrap around, again, I go back to communication because there's so many things just kind of happen you don't know, and the union's been left out, and the disciplines have been left out. The people don't even know what's happening. I remember being in a meeting one time, us with N.L. Health Services, and it felt like a bit of a Twilight Zone moment for me because we were in a meeting, we were questioning pulling a very needed profession out of acute care to start a new program. And it almost felt like we were advocating against the program, which employed our people. And I'm like, this felt so Twilight Zone. Like, in another place and time, you'd be all over, oh my gosh, expand the program, and get more of our people working and build this community resource and all that. And it just felt so weird. But there was so much after the fact communication. No one was consulted. Staff were alarmed because they might be taking 2 staff out of here next week to start something else, and we really need them. Like, we can't do without them. We're running short already. And it speaks to the communication piece. Another thing that I know we're all dealing with is sometimes you get very different messaging from N.L. Health and from the provincial government. That's exhausting at times. And even at times, again, I've had times when we've said something to one of those groups that was going on with the other group, and they didn't even know it. We knew it. The union knew it first. And it was like, it's so unusual when you get into those things. So the communication all the way around just needs to improve. And, with the Health Accord, there's a great blueprint there, but I know many of us have said it's going to be how it's played out. It's going to have to be, it's going to depend on how this gets rolled out and put into action.
Right? Like, plans are one thing, but if you don't follow through, then what's the point of the plan?
Yep.
Right. Any thoughts? Well, we're getting to the point of final thoughts because there's about 5 minutes left, but anything there for either of you? I
can't let the opportunity pass to talk about nurse practitioner funding models.
Yeah.
This is something that, I'm going to argue 15 years, has been on the table. Essentially right now, for a nurse practitioner to work and the patient not pay out of pocket, they have to work within the health authority. There's pros and cons to that, in that the health authority has their priorities as to where they want a program or where they want a nurse practitioner to be. And that may not always align, as Yvette and Gord actually both have said, people may or may not want to live in an area, or they may or may not want to work in an area. Nurse practitioners have been talking about funding model for an eternity.
Yeah.
in that we want to be able to offer that flexibility of care for patients. If you're a family physician in this province, you can work under a salary model for the health authority if you wish. You can bill MCP and be a fully fee-for-service situation. There's some, I'll call it hybrid, in that you do a bit of both or a bit of many things. Or you can even go and do something called a sessional, which means you get a chunk of money for a chunk of work. You can be in primary health care and you can cover long-term care. You can be in primary health care and cover emergency. Like, there's a lot of flexibility to be able to offer, A, the services that need to be offered, but B, the services you want to offer as a professional. And that does not exist for nurse practitioners right now. So that is something that needs to happen. There's been so much dancing around it for quite a while. There's a lot of talk about it for primary health care right now, because I think that's where most people's minds are at. But I think there's a lot of opportunity for that in acute care trained nurse practitioners as well, because in the acute care system, we have so much amazing expertise and specialty, really, in the nurse practitioner world. And those services should not be limited to just the people who are accessing that program. Those services need to be available for everyone. Yvette talked about, we can't have the health science in Placentia. That's absolutely the case. But every single resident of Newfoundland and Labrador deserves a standard of care. And whatever that looks like, it may not be the full health science, in the corner of every little bit of corner of the province, but it's a standard of care that people should be able to have access to. And we have this health accord that's a great start, but that needs to be actioned. We're a lot of times we're taking little pieces out of it and doing it as we want, but it needs to be fully realized for the patients of our province.
Thank you, Margot. Allison.
Yeah, I just want to piggyback on what Gord said a few minutes ago around our rural areas. There has been a long-standing divide from rural to urban centres. It is what it is. And our clinicians that are out there in small numbers have long-standing had much higher caseloads and expectations and had to service multiple program areas all at once. And, we're talking about recruitment, and chances are there's going to be a new grad. That's a very tough place to put them in. But what about if we had two of them there at once so that workload could be manageable and the same as what they would expect if they went to a bigger centre? That two undergrad would certainly be a lot more appealing. So that's what we're talking about, getting creative, talking to the boots on the ground to really understand what are the low-hanging fruit, what are some simple things that we can do to make our recruitment efforts more successful. There you go. We have the answers. We just need to have the right ears to us to hear those thoughts.
Literally 1 minute left. 30 seconds, Yvette.
I'd like to end on a positive note. We are working with the health authority. We're all working with government. We are trying to make it better for the future of the healthcare system. I mean, we're going to be recipients ourselves, right? We're aging. But we need the mentorship piece for getting and, hiring our own. We're training people here in this province, and we're letting them walk away.
Gord, less than 30 seconds.
I'm going to add on to Allison. As health professionals, we are problem solvers. Many times our members not only identify the problem, but they also got the solution in their back pocket. But what they need, all of us, is to be respected and to be heard.
Gord Piercey, Allison Hussey, Margot Antle, Yvette Coffey, thank you so much for this discussion today. And folks, if you have thoughts on the show, thoughts on healthcare, thoughts on the Health Accord, where things are headed, the Signal at cbc.ca. Call the Signal line and leave a message, 709-576-5260. I plugged it once, but I will plug it again. Tomorrow on the show, people over the age of 65 now make up nearly a quarter of Newfoundland and Labrador's population, an increase over 20% since 2019. By the way, we're Canada's oldest and most rapidly aging population. So tomorrow we're asking, how do we plan for this aging population? We will explore staying longer in the workforce, cost of living, long-term care homes, and anything impacting our seniors today. And folks will be the seniors of tomorrow. The lines will be open. Full show tomorrow. Thanks for listening.